hiatal hernia. Hernia, what is hernia?
Weakness of muscles.
I couldn't hear you. See, am I audible now?
Yes, sir.
You are audible, sir.
Yeah, I know some message was there in the chat box, but I'm not able to hear. Okay. So hernia is just protrusion through weakness. Any protrusion through weakness. So what I told you, diaphragm, this is the hiatus. Diaphragm is there is a hiatus here. The esophagus and stomach are like this. Okay. So
can hernia be referred to as an outpoaching, a form of outpoaching? Is that term applicable?
Yeah, it is applicable, but see, it should have hernia should have some prerequisites, like it should have a covering, it should have a sac, then only we can call it as a hernia. If there is no covering, no sac, then it is, see, in gynecology, you might have heard about prolapse.
Yes, sir,
yes?
prolapse.
Yeah, prolapse also is a weakness, there is an outpoaching, okay, but there is no sac there. So we can't call it as a hernia.
Okay.
Okay, yeah. So see here, this is the normal esophagus, stomach and diaphragm. Please the sliding hernia and see the paraesophageal. Two types of hernias are there, sliding hernia and paraesophageal hernia. What is the difference? Can anybody just see that and tell me what is the difference between these two, sliding and paraesophageal?
It's a little off course from the esophagus in paraesophageal hiatal hernia.
In sliding hernia, it's the herniation of the G junction.
Very good.
And
so the G junction itself is moving.
Yeah.
See here, the G junction has moved. Okay, it has moved into the, it has slided into the thorax. Okay, but here, see, the esophageal G junction is there only. Sorry.
The fundus of the stomach, which is herniated.
Yeah, the small stomach outpoaching is there here. So this is the paraesophageal. Esophagus is there. Paraesophageal. It's adjacent to the esophagus. There is a outpoaching. Paraesophageal. So the most common symptom here is the patient will have GERD, because the what I told you, the angle of fish should be maintained. If the angle of fish is not maintained, there is high chance that the patient will develop GERD. So here the patient will have, most common symptom is GERD. And sliding hernia is an elective procedure. You can do a fundoplication. You can just close the hiatus and do a fundoplication. But whereas rolling hernia, that is paraesophageal hernia, is an emergency, because this part of the stomach which went inside can get necrosed. Okay, so we have to do a gastropexy immediately. We have to fix the stomach. Clear?
Sir, so rolling is the fundus of the stomach getting herniated.
Yeah, rolling is the fundus.
Sliding is the esophagus itself.
Esophageal junction, gastroesophageal junction. Okay, so this is an emergency procedure. This is an elective procedure. So for emergency procedure, what used to be done? You have to bring the stomach down and you have to, what we have to do?
Ligate it again.
Yeah, fix it, not like it, fix it. You have to stomach. So that is known as gastropexy. Okay. Yes, no?
Yes.
Yeah. So then esophageal perforation. What is the most common cause? Iatrogenic. Iatrogenic means?
Caused by any kind of procedures.
Yeah, caused by procedure or caused by doctor, basically. We cause it. By doing an endoscopy, we cause it. This is the most common cause of perforation, esophageal perforation. And the most common site is at the upper esophagus, that is the cervical part. And the other causes are barotrauma. If the pressures are increased, sometimes there will be perforation. Corrosive. If the patient consumes some corrosive, some acid or something like that, there will be perforation. And finally, trauma, penetrating trauma can cause perforation. And look at this slide. Have you heard before these terms? Heard or seen before?
Yes, sir. Heard of it.
Both of them?
Yes, both of them, sir.
Yeah, these are very, very important MCQs for your FMG, for your NEET, for your future. So just only five lines in each. Just concentrate here. This is Overhouse syndrome or barotrauma. And Mallory Weiss tear is, this is something related to stomach. This is related to esophagus. This is something related to stomach. But I have brought both them together so that you can remember easily. So what is this Boerhaave syndrome? Suppose the patient is vomiting against a closed glottis. He is vomiting against a closed glottis. What will happen? If you are vomiting forcefully, what will happen? Just tell me.
Retching.
Retching. See, suppose there is a tube. If he is vomiting, but you are not allowing the tube to open. That is, you are closing the glottis. So what will happen inside? What will happen to the pressure inside?
High pressure.
There will be high pressure. Okay, because of this high pressure, there will be a small giveaway. So this is known as barotrauma. Boerhaave syndrome is nothing but it is barotrauma. Okay, so that is one. And next, it occurs in the lower left posterior esophagus. Suppose this is the esophagus. This is the upper. This is the lower. It occurs on the left posterior only. Lower left posterior esophagus. Okay, it happens as a full thickness rupture. The esophagus will rupture completely. They will have a full thickness rupture. So if it ruptures, what will happen to the contents of the esophagus? Where will they go? The contents?
Aspiration
Sorry?
to lungs. Aspiration to lungs.
No. Before aspiration, where will they go? The contents, it ruptured. The esophagus ruptured here.
Mediastinal area.
It will go into the mediastinum. So the patient will have vomiting, the patient will have pain, and the patient will have effusion. Pleural effusions will be there because it is there in the mediastinum. So this triad is known as Mackler's triad. So it is a full thickness rupture. So you have to open, you have to do incision, open it, and you have to close the esophagus. These are the 5 points. Again, I will repeat once. Boerhaave syndrome or barotrauma, it is nothing but the patient is vomiting against a closed glottis. So there are high pressures within the esophagus. It is barotrauma. What is barotrauma? Trauma due to pressure. So it is because of this, because the patient is vomiting under high pressures, there will be a full thickness rupture of the esophagus. The contents are going into the mediastinum and will cause effusion. So the patient will have vomiting, the patient will have pain, the patient will have effusion. This is known as Mackler's triad. Because it is a full thickness rupture, we have to open it and we have to close it. We have to do a surgery. This is about Boerhaave syndrome. Okay, this is one. And next, Mallory-Weiss tear. It is in the stomach. It is also vomiting against a closed sphincter. Lower esophageal sphincter is closed here, not the glottis. The lower esophageal sphincter is closed. The patient tries to vomit, but the sphincter is closed. So here, there will be a small tear. There will be a partial tear. It is not a complete tear. It is a partial tear. So it will go into the lesser curvature near the OG junction. Suppose this is the stomach. This is the greater curvature. This is the lesser curvature. Lesser curvature near the stomach. There will be a small tear. This is known as a Mallory-Weiss tear. It is a partial tear. The patient presents with self-limiting hematemesis. He will have one episode of hematemesis. What is hematemesis?
Blood and vomiting.
Single episode of hematemesis will be there, and it is self-limiting. So do we need to do a surgery?
No.
No need.
So just do endoscopy and confirm that it's enough. Okay. Clear both of them?
Yes, sir.
Clear, sir.
Yeah, remember in this order only, so that both will be easy to remember. Boerhaave is an emergency because it is a
Full thickness tear.
Esophageal tear.
sorry.
Full thickness
The full
rupture.
thickness
Full
rupture,
thickness
actually.
It's a full thickness rupture. Very good. Mallory-Weiss tear is a partial thickness rupture. It is not an emergency. Remember the sites also. Mallory-Weiss tear, it occurs at the lesser curvature near the OG junction, whereas Boerhaave syndrome occurs at the left lower posterior esophagus. Okay. This also is important. Lower left posterior esophagus, and it is lesser curvature near the OG junction. Okay. Okay. If it is clear, this slide, I want you to mug it up or remember somehow because very important. Okay.
Okay, sir.
Yeah. And now we'll move on to poisonings, alkali or acid poisonings. Corrosives. So alkali, large amounts are ingested, whereas acid only small amount is ingested. The reason is obvious. Why?
pH. So obviously
Sorry?
pH acid will be corrosive, so it corrosives the mucosa when the
No,
patient is trying.
nothing logical thing in this. Just I have see if a patient comes to you with acid poison injection, you will tell I have taken only small. If he is having alkali poison, alkali injection, he will tell I have consumed large amounts. See, because if you take acid, it is not tolerable at all. Simple thing. So once you take, he ingests something, he will burn, and patient will consume only small amounts. But alkali, he will take large amounts. So if you take the alkali, there will be liquefactive necrosis. In acid, there will be coagulative necrosis, and there will be no perforation because only a small amount is there. There will be no perforation. There's just coagulation of protein. It will be done. But in alkali, there will be perforation. Okay, esophagus is more burnt because of alkali. Because of large amount of ingestion of alkali, esophagus is affected. Whereas acid, stomach, because whatever he swallows, that will cause stomach too. And alkali, long-term damage continues. Acid, we think it is dangerous, but it is long-term damages are very rare in acid ingestion. Okay, is this slide clear? Okay. So how do you manage a case of esophageal perforation? Non-operative management. Non-operative management, there is a criteria. See, endoscopic perforation. If a perforation is by endoscopy, doing endoscopy, small septic foci of perforation, cervical esophagus perforation, and draining collection in the medium. If there is collection in the medium, we can just drain the collection in the medium. For this, we can do non-operative management. No need to operate. So the investigation of choice is CT thorax with contrast. You do a CT thorax and you give some contrast material. So with this, we can tell whether there is any leak in the mediastinum or not. Okay. And X-ray chest also, if you do, you can see there is mediastinal air. See here, see the arrows here. Are you able to appreciate it? Normally there should be no air here, right? Air should be in here, in the lungs. Here there should be no air. If there is air here, from where did it come? From the esophageal perforation only. So this is known as V sign, Neclarios V sign, mediastinal air or Neclarios V sign. Are you able to appreciate it? Yes, no? Come on, please. Yes, no?
Yes,
Yes.
sir.
Yeah. So if you are able to see that air in the mediastinum, that means there is some perforation. Okay. Now we'll move on to the next topic. What are the causes of dysphagia? What is this? PWS, causes of dysphagia. Yesterday we are discussing plumber nodule, Graves' disease and plumber nodule. Then somebody was asking, is it same as Plummer-Vinson syndrome or not? So PWS is Plummer-Vinson syndrome. Okay, and PKS is Patterson-Kelly syndrome. Both are same. So it is a disease of young females. The patients are anemic. They have a post-cricoid web here. Post-cricoid web. They develop a post-cricoid web. Okay, it is also known as siderophenic dysphagia, and it predisposes to squamous cell carcinoma. Whereas GERD predisposes to which cell, which type of carcinoma? Adenocarcinoma. Here it is squamous cell carcinoma. So remember 5 points. Young females, they have a post-cricoid web. This is known as anemia. The patients will are almost they have anemia. It is known as siderophenic dysphagia. Siderophenic dysphagia. It predisposes to squamous cell carcinoma. Okay. And Jackie's ring.
What does it mean, siderophenic dysphagia?
Siderophenic means siderophenic, iron related. Just it is other name of it. Siderophenic. Sidero means iron.
Okay.
Iron related and dysphagia. Because of lack of iron, anemia, the patients have post-cricoid web. This is a syndrome. Both the features are there. Both anemia is there and web is there. Because of this web, there is dysphagia. Okay. Is it okay?
Okay.
Yeah. And the other things are Zaki's ring. It is most commonly located at the squamous columnar junction, squamo-columnar junction. That is the esophago-columnar, squamo-columnar junction. It is a submucosal thin ring, and treatment is put in endoscope and dilate it. Endoscopic dilatation. Most common at the squamo-columnar junction. A submucosal thin ring is seen. A submucosal thin ring, and treatment is by endoscopic dilatation. Dysphagia lusoria. Heard before this term? No? Yes?
Yes, sir, heard of it.
Yeah. Because of this aberrant right subclavian artery. Suppose see, this is the esophagus. The artery will be compressing. The vessel will be compressing the esophagus. This is dysphagia lusoria. Aberrant right subclavian artery. It compresses the esophagus posteriorly. Okay. The patient will have dysphagia. And this is the tracheoesophageal fistula. Morning I was telling you tracheoesophageal fistula. So see here, this is the esophagus. One. This is the esophagus, and he has a fistula here. This is only atresia, esophageal atresia. This is having a fistula. This is having a fistula here. This is having fistula both upper and lower, and this is having stenosis, only stenosis. So these are type 1, 2, 3, 4, 5, like type A, B, C, D, E. So type C is the most common. Okay.
This image
Yes.
was in the exam to tell which type it was.
No, it is not asked in such way. They'll ask you what is the most common type of tracheoesophageal fistula.
No, in June it was there. One of the
Okay.
questions was there. Yeah.
Which type they asked you?
Yeah, they placed the image and they asked which type it is.
Okay. So I'll just tell in detail then. Tracheoesophageal fistula. The classification system is gross classification. We call it as gross classification. Okay. The classification is gross classification. So see here in type A, esophagus is here. It is there. Here it is there. It is there. So it is atresia only. Esophageal atresia. There is no fistula actually. There is only esophageal atresia. Okay. Type 1. Type A. Type B, there is here the esophagus is connected with the trachea. Below it is not connected. So this is a esophageal atresia with proximal fistula. Proximal fistula. Okay. See here. Here there is only esophageal atresia and there is distal fistula. Distal fistula. Okay. See here. Here there is esophageal atresia with proximal and distal. Both are there. Proximal and distal. And here there is only stenosis. There is only stenosis. Okay. So now I think you can answer it. So type A, esophageal atresia. Type B, atresia with proximal TF. Type C, esophageal atresia with distal TF. And type D, esophageal atresia with both proximal and distal TF. And type E is only stenosis. Is it clear now?
Yes.
So I think now this, what was the exact question in June?
I will tell you later in the afternoon what exactly, but they actually gave the picture and to tell which type of
Is the most
fistula
common or
is.
which type is?
No, which
they
type
asked-
is what? So they gave the image of three or four images and they asked which type it is.
Okay.
Look at the image and tell which type it is.
Okay. I think now you can tell it, right? Which is proximal, which is distal.
Yes.
Okay. And coming to esophageal ulcers, there are two types of ulcers. Punched out ulcers. Punched out ulcers. They are seen in herpes simplex virus infections. Punched out ulcers. Herpes simplex virus infection. And the other is serpentine ulcers. Serpentine ulcers. They are seen in cytomegalovirus infection. Serpentine ulcers are seen in cytomegalovirus infection. Okay. Till now, is it clear? We are going on to the last part of esophagus, malignancies. Till
Yes,
now, is
sir.
it clear?
Yes, sir.
So many
Yes,
concepts we
sir.
have discussed. Yeah, and some important things like Malrivage tear, Boerhaave syndromes we have discussed. And we have also discussed about Jackie's ring. What is Jackie's ring?
Most common site.
Yeah, most common site is
Squamous-columnar
squamous-columnar junction. But what is that ring? What is that ring? Is a
In
mucosal ring or submucosal ring?
submucosal therapy.
It's a submucosal ring. What is the treatment for it?
Dilatation, endoscopic
Dilatation. Endoscopic dilatation is enough. And why is it? Why this ring came actually? It is a complication of
Plummer-Wilson or
no. It's not a complication of Plummer-Wilson. It is a complication of
Diffuse esophageal spasm.
sorry.
Diffuse
GERD.
It's a complication of GERD. Yes.